So hello friends, I hope I'm audible and visible. Just give me a quick thumbs up if my audio video is fine. Let me very quickly check if you all can hear me properly or not. Just give me a second. So welcome in this dermatology session with me, Dr. Chesta Aggarwal, your NEET PG educator with the best online platform, that is Unacademy. So yes, we have an MCQ based discussion right now going on. I am Dr. Chesta Aggarwal, your NEET PG educator on Unacademy. Now on Unacademy right now we are providing you a 20% discount. So if you have to take Unacademy subscription, use my code CHESTA10 and get 20% discount. Now the new batches which are about to start, this is the target NEET PG 2023 batch. Then we have a NEET PG 2023 TND batch, and the last is you have increase in the prices of Iconic. So I request each and every one of you to please kindly go ahead and get your subscription today. Now today we have a little difficult questions with us, so just a second, I'm starting the PPT for everyone here. So let's start with today's first question. The question is, we have a 10-year-old female with multiple reddish brown lesion which started over the face. Further progress to involve the upper limb trunk since past 2 years. She gave a history of elevation and redness associated with itching on the lesion after few minutes of rubbing. There was no associated systemic symptoms. The personal and family history was not contributory, and on examination there were multiple hyperpigmented macule over the forehead, face, neck, upper limb, trunk. What can be the diagnosis? So good morning to all my dear students. I request all of you to please answer this question. So 10-year-old female presented with the following lesion. What can be your diagnosis here? Okay, now Ruhi, I want you to notice a very important sign which is mentioned here, and this is this one. She gives a history of elevation and redness, itching when you rub the lesion. Is there any such history with pityriasis rosea? The answer is no, because the description is a very classical description of Darrier sign, and we all know that Darrier sign is positive in urticaria pigmentosa. So this is a case of cutaneous mastocytosis, which is called as urticaria pigmentosa in children. Here you have accumulation of the mast cell in the skin. When the mast cells are stroked, or when you rub these lesions, there is sudden degranulation of the mast cell, and because of this degranulation, a lot of mediators comes out like histamine, causing features of wheal. So please remember, the answer here in this question is option number 1, that is urticaria pigmentosa. If this point is clear, I request a quick thumbs up from each and every one of you. This is a very interesting, easy question, I guess. Clear, Arui? Next question. So please move to the next question. Anyone can tell me the answer here? A 54-year-old male patient presented in the hospitals with the history of ulcerated lesion on the dorsum of his left hand with ascending, the lesions are ascending in the left arm. He was treated in the community with several courses of amoxicillin, clavulanic acid, but there was no improvement. There was no history specific to any injury, although He was a keen gardener. He has no significant past medical history and he did not take any regular medications. There was no history of overseas or interstate travel. On examination, there was a 5 into 4 centimeter ulcerated lesion on the dorsum with nodular lymphangitis. What can be the diagnosis? What can be the diagnosis? Anyone? The correct answer here is, you are right, Rui, this time this is sporotrichosis. Now again, I would like to mark the important points in the question. First, very important point is, patient is a gardener. So in gardeners, there is a frequent trauma with the damp wood, which is usually the source of fungus. Second thing is, the ulcers, they are present in a linear fashion or in the ascending fashion. That is the sporotrichoid spread. Now why do you see such linear spread in the patients? Because what happens, the sporotrichosis infections occurs in the lymphatics, and because of the lymphatic spread, they ascends in a linear pattern. So please remember, the answer here is option number 1. Clear? Anyone with the next question? I want all of you, those who are awake and those who are live in my class, to please answer this. Not only few students. I want this class to be a little more interactive, and I would be requesting all of you, all my students, if you like the way I teach and if you want me to take the whole dermatology, then please go ahead and get my subscription, or get your subscription using the code CHESTA10, CHESTA10. We are providing 20% discount right now, so anybody interested can go ahead and get the subscription. Now let's come back to the question. The question says that we have a 28-year-old mechanic who was referred with a 3-month history of blistering, non-healing wound on the right knee. Patient complains of numbness of the affected area, but when examining the patient repeatedly, we have seen that there was no sensory deficit. The bulle was firm, non-tender, without any signs of inflammation of the surrounding skin. No specific causative factor was identified, and the detailed general physical and systemic examination was normal. The culture from the bulla fluid was sterile, and the routine laboratory tests were normal. The answer here is option number 1, dermatitis artifacta. Now here you can see a lesion which is not having, or which we are not able to identify any causative agent. We have a vague physical examination, we have a vague history here. So please remember, whenever you get such a patient, you have to suspect dermatitis herpetiformis. Very nice, Ravi, very nice, Ruhi. Next question. I hope the image is visible. Let me just quickly move it on the left so that yes, you will understand. Good. Tell me what is the correct answer of this question. The mother, who was 50-year-old, had several soft tissue lesions presented with a lesion which is shown here. You can see a very classical lesion in this patient. All her offspring had a similar lesion in a variable sizes and frequency. Which statement here is false, or which of the following statement is not considered true? So can anybody tell me what can be the diagnosis here? Anyone? The diagnosis here is neurofibromatosis 1. Now I want you all to look at the image first. Look at the image. There is a large mass which is present here. This is nothing but plexiform neurofibroma. Then we have this hyperpigmented lesion. This is a cafe au lait macule. And can you see these small nodules? These are neurofibromas. So this is a patient with multiple features of neurofibroma presenting together. Now the question is, which of the following statement is false? The hyperpigmented macule seen here, that is cafe au lait macule, is present since birth. This is true. Large mass seen, the plexiform neurofibroma, is not considered as diagnostic criteria. No, it is considered as the diagnostic criteria. And in fact, if you have a single plexiform neurofibroma, then also it is considered to be significant. Autosomal dominant condition, true. Slit lamp is important. Why? Because we need to do iris leash. We want to see iris leash nodules. Because we want to see iris leash nodules. The next question is on your computer screen. A 27-year-old healthy woman with allergic rhinitis presented to emergency department reporting a 4-day history of fever, odynophagia, sore throat, purpuric skin lesions, muscle aches, as well as unilateral elbow, ankle pain. Patient confirmed unprotected oral and vaginal sexual intercourse exclusively with her partner for past 6 months, and gram stain shows a positive blood culture revealing gram-negative diplococci. What is your diagnosis? Anyone? The correct answer here is disseminated gonococcal infection. A gram-positive blood culture revealing gram-negative diplococci, very characteristic of disseminated gonococcal infection. Sometimes the gonococcal infection ascends upwards with the help of blood. There is hematogenous spread of the organisms. Now, why this is not Purpura fulminans NKN? Because the diplococcus here, which is shown, you cannot prove it with the Purpura fulminans like of appearance. Okay. Next question. A 29-year-old female presented with gestational diabetes and hypothyroidism, diagnosed in the first trimester of pregnancy, presented at the 32th week of gestation with pruritic urticarial plaques located in the navel area with subsequent extension to the abdomen and leg. Due to dermatosis exacerbation after delivery, she was referred to the dermatologist. Physical examination reveals annular edematous plaques associated with the vesicles and tens bulla, and there was hemorrhagic crust dispersed throughout the limb. What is the antigen against which you will develop the antibodies? Anyone? Very nice, interesting. Ruhi, KKN, Srinati, Can you tell me what is the diagnosis here? Anyone? What is the diagnosis? What is the diagnosis here? This is the diagnosis of anyone? This is a diagnosis of pemphigoid gestationalis. This is the diagnosis of pemphigoid gestationalis, and please remember, in the pemphigoid gestationalis patients, what is the feature or what is the antigen? It is BP 180 antigen against which you develop IgG type of antibodies. Okay, it is the very nice IgG type of antibodies are developed against the BP 180 antigens. Next, can you answer this question for me? So I'm waiting for everybody's answers here. A 79-year-old man was admitted to our hospital with nasal bleeding and there is left cheek swelling suggesting of maxillary sinus carcinoma. So we have a 79-year-old male with maxillary sinus carcinoma and a solid mass with aggressive bone destruction was detected in the left maxillary sinus on contrast enhanced CT. For a month, the patient had noticed systemic erythematous rash of the upper eyelid, erythematous plaque on the dorsal surface of his proximal interphalangeal joint, erythematous area at the bases of the finger, dysphagia, proximal muscle weakness of both the extremities. What is the answer? Yes, this is a patient with dermatomyositis, and please remember around 40% of dermatomyositis patients have nasopharyngeal carcinoma. Around 40% of the dermatomyositis patient has nasopharyngeal carcinoma. Is that clear to all of you? So look at this, there is a maxillary sinus of the nasopharyngeal region, then the erythematous rash on the upper lid. What is this? Heliotrope rash. The erythematous plaque on the dorsal part of the proximal phalange. What is this? This is the Guthrun's papule, and erythematous area at the base of the fingernails, that is the ragged cuticle with proximal muscle weakness, all features suggestive of dermatomyositis. Another question, it's a very interesting one. I want all my students to kindly answer this question for me. So the question is, we have a 3-year-old female Indian presented with night blindness of 1 month duration as ascertained by her parents. On examination, the visual acuity appeared to be normal. Conjunctiva appeared lusterless, suggesting xerosis. And the anterior segment and a dilated fundus examination with indirect ophthalmoscope was unremarkable. Further examination reveals dry horny papules with central intrafollicular plugging distributed over the extensor aspect of the elbow, knee, trunk and back. She also had a dry, coarse and lusterless hair. What is your diagnosis? What is your diagnosis? The correct answer of this question is option number 1. Now why do I say that? Because first of all, there are features of night blindness which you see, and second is we can see that there is some dryness on the conjunctiva. When we examine the patient, we can see that there are some horny papules with central intrafollicular plugging, features like phrinoderma, and all this give you an idea that we are dealing with a patient with phrinoderma and vitamin A deficiency. Next question. 59-year-old lady presented to outpatient department of endocrinology for routine follow-up after 6 months for diabetes mellitus. She was a diabetic for the last 5 years, which was under control with oral anti-diabetic drugs. Her only concern was a reddish brown papular rash with erythematous spreading borders on the anterior aspect of both the legs over the shin. The rash was tender, non-blanching with reddish flecks over it. It is not itchy and it is present for last 10 days. She was asymptomatic without any significant past medical history, and there was no history of past surgical procedures, undue medicine intake, allergy to drug or environmental agents. What is your diagnosis? Very nice. This is a patient of necrobiosis lipoidica. Option number 2. What is this? In a prolonged or a long-standing diabetes, what happens? You have microangiopathy. The blood vessel wall becomes abnormal. When the blood vessel walls becomes abnormal, the blood easily goes out of the blood vessels, right? It goes easily out of the blood vessels. And when it goes out of the blood vessels, what happens? You have deposition of the red blood cells in the skin. This initiates some necrosis or damage to the skin, which is known as diabetic dermopathy, or ultimately it will give rise to necrobiosis lipoidica. Okay. Ravi Ranjan, please remember pemphigoid gestationalis. So Ravi Ranjan is asking, ma'am, pemphigoid gestationalis is associated with which? BP antigen 1 and BP antigen 2. So pemphigoid gestationalis is associated with, please remember, BP 180, which is BP antigen 2. You develop antibodies of IgG type against BP antigen 2 or BP 180. What is the fate of necrobiosis lipoidica? Fate is, see, these are the necrotic lesions. So if it is not taken care of, it can even give rise to severe infections or can lead to gangrene. So first of all, you have to ask a diabetic patient to keep a control of diabetes. It should not be uncontrolled. Proper drug modifications is required. Second is, we ask the patient not to keep the leg, like avoid standing. We ask the patient to keep the leg against the gravity so that not much blood seeps out of the blood vessels. Understood? Clear hai? So KN and Ravi, I hope I'm able to clear everybody's doubt. Next question. But once it happens, necrobiosis lipoidica, it's very difficult and very cumbersome for the patient. Now, a 1.5-year-old boy presented with generalized scaling over the whole body and redness over both the cheeks. On examination, there was a fine white to brown scaling over the whole body without any spade areas, with glistening surface over the palm and sole, with involvement of flexures. We have left-sided cryptorchidism, for which the patient was referred to the pediatric surgery. Histopathological examination was done, which revealed mild hyperkeratotic and hypergranulosis. What could be the diagnosis here? What could be the diagnosis here? What could be the diagnosis here? Epidermolysis hyperkeratosis, X-linked ichthyosis, lamellar ichthyosis, or ichthyosis vulgaris. Anyone? A 1.5-year-old boy with generalized scaling over the whole body and redness over the cheek. There was fine white to brown scaling over the whole body without any spared areas with glistening surface over palm and sole. Left-sided cryptorchidism was present, for which the patient was referred to the pediatric surgery department. An histopathological examination was done which reveals mild hyperkeratosis and hypergranulosis. What is the diagnosis? This is a patient with X-linked ichthyosis. And what are the points which favors? Please look at this. I told you in the beginning that there are few features which help us differentiate all the other options in your exam also. So cryptorchidism was present. On doing the histopath hypergranulosis, we have generalized scaling. So it's a patient of ichthyosis and the scales were brown and there is no any spared area. So these are some of the points. For example, in ichthyosis vulgaris, they will give you a history of light color scales with sparing of flexures. No cryptorchidism, and on hypo or on histopathology there is hypogranulosis. So you can easily rule out ichthyosis vulgaris. For lamellar ichthyosis there should be a history of colloidal membrane. And please remember, epidermolysis hyperkeratosis presents with bullous lesions, not with this history. So very classical of X-linked ichthyosis. What are the specific signs and symptoms of ichthyosis vulgaris? Please remember, ichthyosis vulgaris will present with, I've told you just now, present with light color or yellow color, small sized scales, mainly on the extensors. The flexures are spared. The flexures are spared. The flexural areas are spared. This I am talking about ichthyosis vulgaris because few students are asking about ichthyosis vulgaris. Now please remember, it is an autosomal dominant condition and it is associated with underlying atopic dermatitis. When I do histopathology in these individuals, I will see hypogranulosis. So these are the features which you see in the patients of ichthyosis vulgaris. And for X-linked, I have already mentioned what are the important features. Can I get a quick thumbs up? Ruhi, KN, Farhat. Very easy and interesting. Let's move to the next question. Ratan, who is 11 years, born of non-consanguineous marriage, presented with asymptomatic pigmented lesions on the upper limb. His parent did not have similar lesions. On examination, a hyperpigmented patch was seen, extending from the flexural aspect of the arm, forearm, till the dorsum of the hand. Involvement of the upper back and scapula with hypertrichosis was noted, and the remainder of the physical examination was normal. What is your diagnosis? Remainder of the physical examination was, what is the diagnosis? Melanocytic nevus, Baker's nevus, sebaceous nevus, comedo nevus. What is the answer? Ratan, a 11-year-old boy, what is the correct answer here? So this is a adolescent male which presented with the features of hyperpigmented lesions extending on the arm, forearm, upper back and scapula, and there is hypertrichosis associated with this. This is a patient with Baker's nevus. Okay, this is a patient with Baker's nevus. Is that clear to all of you? This is a patient with Baker's nevus. I hope there is no confusion with this. Can I get a quick thumbs up from all my dear students? This is a very classical image of Baker's nevus. Baker's nevus the nevus cells have androgens on them. The nevus cells have androgens on them and because of these androgens, they become very prominent at the time of what? At the time of puberty. No, Baker's nevus will not subside with age, because we are not reducing the androgen anytime after puberty. So it remains like that. Usually nothing is done, you just have to counsel the patient. But if the patient insists, you can go for some procedures like laser therapy, but still the prognosis is not very good. We will not see a complete resolution of Baker's nevus even on starting with the laser for pigment. Okay, so just counsel the patient that it is a benign nevus, it will not cause any harm to the patient. Moving to the next one. An 18-year-old presented with 8-month history of an asymptomatic dyspigmentation of the skin on his face, neck, bilateral arm that had gradually worsened. He denied preceding cutaneous redness, scales, pain or pruritus. There was no truncal or local extremity involving, but he did not admit to the frequent sun exposures and lack of sun protection. No one in his entire family had a similar lesion, and he denies any personal or family history of autoimmune disease. On histopathology, a patchy vacuolar dermatitis with melanin incontinence, dermal melanophages, and mild dermal atrophy was seen. What can be the diagnosis? Clear? So 18-year-old presented with the 8-month history of asymptomatic dyspigmentation of skin. There was no truncal or lower extremity involvement, but he did admit frequent sun exposures, lack of sun protection. No one in his family had a similar lesion, and he denies any personal or family history of autoimmune disease. On histopath, a patchy vacuolar interface dermatitis with melanin incontinence is seen. The diagnosis is. Very well done. The presence of patchy vacuolar interface with melanin incontinence, dermal melanophages, dermal atrophy, all these suggest the diagnosis of lichen planus. Plus, question says that the patient has dyspigmentation of the skin of the face. This is a variety of lichen planus which is known as lichen planus pigmentosus. Lichen planus pigmentosus. The name of the question is, or the name of this is lichen planus pigmentosus. If this is clear, can I get a quick thumbs up from all my dear students? Lichen planus pigmentosus. Next. A 6-year-old boy with complaints of frequent painful ulcerations of the oral cavity since 3 years. His parent gave a history of skin erosions on the back arm at the time of birth. Since then, the erosion appeared all over his body at the slightest trauma and healed by scar. His finger and toenails are absent. What is the answer? So a very specific history. I hope I'm audible and visible to all of you. Can you all give me a quick thumbs up? I hope I'm audible and visible. Ruhi, Farhad, KN, can I get a quick thumbs up if my audio video is going fine? Very nice, amazing. So this is a patient with a mechanobullous disorder which is presenting since birth, and because the lesions are healing by scarring, this is a patient with EB dystrophica. Healing with scar is seen mainly in the patients with EB dystrophica. The correct answer of this is option number 3. Clear? Can I get a very quick thumbs up from all of you? Now moving to the next question. Mr. SL was a 35-year-old driver who presented at the emergency unit with a 2-week onset of fever, dysentery, dysuria, joint pain. The joint pain involved the left wrist, the right knee, and the ankle. There was urethral discharge but no hematuria or genital ulcers, and there was associated discharge from both the eyes with redness but no chest symptoms. There was a history of multiple sexual partner. What can be the diagnosis? Reiter's disease, rheumatoid arthritis, or osteoarthritis? What is the correct answer? Anyone? Very nice. You can see that in this patient we have a very characteristic triad of, what is the characteristic triad? The patient with fever, dysuria, so urethritis, joint pain, arthritis, and conjunctivitis. This is a patient with Reiter's. Can anybody tell me what is RITTER Reiter stands for? What is RITTER Reiter's stand for? What does RITTR stands for? And yes, this is the another name for staphylococcal scalded skin syndrome. This is another name for staphylococcal scalded skin syndrome. Is that clear to all of you? Can I get a quick thumbs up from all my dear students? Next. 60-year-old female with no past medical history presented with a well-defined hyperpigmented plaque in the axilla. Woods lamp examination showed coral red fluorescence. Samples from the macerated interface were sent for 20% of potassium hydroxide preparations. Tissue culture has the following features. What is the diagnosis? The specific feature which we can notice here is we have coral red fluorescence. Just let me highlight this for you. We have coral red fluorescence with a very classical feature of Corynebacteria species. So these two features will actually help us in diagnosing a very important disease, that is erythrasma. There is a very important disease which is erythrasma. So we have a 60-year-old female with no past medical history, presents with well-defined hyperpigmented plaque in the axilla. The Woods lamp examination showed coral red fluorescence, and sample from the macerated interspace shows 20% of potassium hydroxide. The diagnosis becomes erythrasma. Am I audible and visible to all of you? Now, the next question. There is some connection issues going on at our place. So I'm very sorry for that. The internet is also not very proper today. But I hope you all can hear me and the question is visible right now. This is a very interesting question and I want everyone to please read it carefully and try to do it. A very interesting question. I've seen a few questions in the past from the same topic. Ruhi, okay, so I'll try to do that, but I would be recommending all of you that please go ahead. Anybody who is an Unacademy subscriber will find the PDF on the class or on their app. So please download the Unacademy learning app Chesta 10. Use this code, get your subscription. You will easily get the PDF of this class. Okay. What is the most common age of presentation of erythrasma? Now, KN, erythrasma is actually a disease which occurs because of lot of secondary corynebacterial growth. Now, there is no particular age, but we usually observe erythrasma in the middle-aged adult. Okay, because there is a lot of sweating. When you have a lot of sweating, what happens? There is growth of corynebacteria, and when there is growth of more corynebacteria, these patients develop erythrasma. So there is no particular stage. Okay. Ruhi, again, the same thing. Like if you are a plus subscriber, you can find the PDF of this YouTube session as well. So I'll let you how, but on the Telegram I might not be able to share this. Okay, so I'll try my best so that it can reach it to you. Okay. Now in this question, the question says that we have a 40-year-old married female hailing from West Bengal complains of inability in combing the hair. Now please listen to this. She has a main complaint that she has a complaint that she is not able to comb her hair. The reason is because there is some blackish nodules attached to her scalp. Okay, attached to her scalp. Now I want all of you to please look at this. Can you have a look? Can you see that there are some nodules at equidistant on the hair? Can you see that? So here also you can see 1, 2, 3. Here also 1, 2, 3, 4, 5, 6. If you all can see this, I want a quick thumbs up from everyone, because I know it's a little difficult for you to find out, but if you can, then please say yes. All of you, Kian, Ruhi, everyone, if you can see. Yes? This is nothing but a black piedra, which is a fungal infection. It is a black piedra which occurs because of piedra hote. It is a fungal infection. So patient develops some hard concretions on the hair. So when you comb the hair, what happens? When you comb the hair, there is a gritty sensation which a patient feels, and the hair becomes very irregular. They get more tangled. There is a raspy sensation which they feel. So that is how a patient of black piedra presents. Clear? Next question, a 70-year-old female comes with multiple erosions, flaccid bulla over the skin. Slight rubbing of the skin results in exfoliation of the outermost layer, forming a blister within a minute. Erosions were present over the oral mucosa. No target lesion seen. What can be the diagnosis? Now question is multiple erosions, flaccid bulla. Something which I want my students again to remember here is slight rubbing of the skin result in exfoliation of the outermost layer, forming blisters within few minutes. What is the diagnosis here? Anyone? What is the diagnosis here? Please remember, this is a Nikolsky sign. What is this? This is a Nikolsky sign. And Nikolsky sign with flaccid bulla, erosions in the oral mucosa, gives you an idea that you are dealing with pemphigus vulgaris. Now, even though pemphigus vulgaris is a disease more frequently seen in a young individual, but rarely you can see the lesion in the elderly age group also, or in a middle-aged or elderly individual also. So the correct answer of this question is option number 1. Next, anybody can tell me the answer? We have a 30-year-old male, severely itchy, papulovascular lesions on the extremities, knee, elbow, buttock for a year. Direct immunofluorescence staining of the lesion showed IgA deposit at the dermoepidermal junction. What is the most probable diagnosis? Pemphigus vulgaris, bullous pemphigoid, dermatitis herpetiformis, or IgA pemphigoid? What is the answer here? We have a 30-year-old male with severely itchy papulovascular lesions on extremities, knee, elbow, buttock, and the DIF staining of the lesion shows depositions at the dermoepidermal junction. What is the most probable diagnosis here? Very nice, everyone. Presence of papulovascular lesions on extremities, elbow, knee, and IgA deposits all points towards the diagnosis of DH, dermatitis herpetiformis. All points towards the diagnosis of dermatitis herpetiformis, where you see grooved lesions, very classical dermal papillary tip microabscess, and you will see granular deposits of IgA. What is dermatitis herpetiformis? KN, I cannot explain that in just 2 to 3 minutes. It is a type of vesiculobullous disorders which is usually a manifestation or cutaneous feature of underlying celiac disease. I would highly request all of you that vesiculobullous disorder is a very important topic for your exams. So anybody who seriously or sincerely wants to clear their exam, please get your subscription and please join my plus classes starting soon. This is my quote. These are just few trailer questions. We have much more on the app. So requesting all of you to please get diverted yourself on the app for more detailed discussions of all the things. Okay. Next question. So thank you, Ruhi. Thanks a lot. I would also request other students to try attending the plus classes. You can take the shortest subscription of Unacademy, because at Unacademy we give you small subscriptions of 1 month, 2 month, 3 months, and so on. And in that window of 1 month, you can access all the past courses and the present courses which is available on the app. So requesting everyone to please get your subscription today. The next question, or the question here with us, is a 35-year-old male serving in the military presented to the clinic with long-standing burning irritation of bilateral plantar feet. He was seen by multiple physicians and was prescribed different antifungal treatment over the several years, but there was no improvement. Patient's past medical history was unremarkable, and we could see diffuse maceration of the skin with hyperhidrosis and areas of pitting of the skin on the plantar weight-bearing surface. What is the diagnosis? How to differentiate dermal bullous lesions? KN, dermatitis herpetiformis is a dermal bullous lesion. So why you need to differentiate it from that? It is one of the example of dermal bullous lesion. So we have divided vesiculobullous disorders into two groups. The intraepidermal, which includes pemphigus, and subepidermal, which includes the bullous pemphigoid group, dermatitis herpetiformis, EB junctional, EB simplex, etc. So we cannot differentiate it because it is a part of dermal blisters. Okay. The answer to this question is yes, you are right. Pittate keratolysis, the punctate lesions on the undersurface, a very classical image of pittate, or a very classical description of pittate keratolysis. Pregnant female with sudden onset of multiple generalized vesiculobullous lesion almost all over the body, associated with pain, mild fever, bilateral knee joint without any redness, swelling. What is the answer? Anyone can tell me the answer here? A pregnant female complains of sudden onset of multiple generalized vesiculobulous lesion almost all over the body, associated with pain, mild fever. She has bilateral knee joint without any redness or swelling. One of the examination of the lesions are found to have pustular tip with red hue. What is the management of this patient? So she is a pregnant patient who presented with generalized vesiculobulous lesion almost all over the body. But when we examined, they were nothing but the pustules. So can you help me out with this question? Yes, it is a patient with pustular psoriasis of pregnancy. And how do you treat a patient of pustular psoriasis of pregnancy? Anyone? Ravi, Sachin, Ruhi, Enken. For the pustular psoriasis of pregnancy, please remember the treatment which we give is steroids. Okay, so the correct answer of this question is steroids. So I think with this we all are clear, and it's very easy for you. Can you all give me a quick thumbs up if the today's session was easy and interesting and clear for all of you? So let's end the today's session. Thank you all of you for your patience listening. Just a quick request that we are having some offers going on right now, so I would be requesting all the students to kindly go ahead and get this 20% discount, which is a limited time period offer. You can find this by, or you can use this using my code CHESTA10. So thank you all of you. Good day and take care. We have a class at 5 p.m. again on the app, or sorry, on the YouTube. So hope to see you all at 5